looking at pharmacology, it's only about 20 pages long. So we've got time to go over and discuss things because we have 2 hours to go over this, and then I think we're going to go over IO as well. So pharmacology, we'll start at the beginning and we'll work our way through. So what are our medication sources? What are our 4 basic sources?
You mean routes?
Nope, our medication sources.
You got plant, animal, material, and synthetic.
Okay. All right, so what are some medications we see that are derived from plants? If you're following along, I highly suggest you look at page 258.
Opioids.
Okay. So we have atropine.
You got atropine, morphine. I don't know how to say the digital.
Uh-huh.
And then you got D50 that came from sugarcane.
Okay. All right, so how about animals? What drugs do we have come from animals or medications?
Oxycontin, insulin, different vaccines.
Okay. Minerals.
You got sodium bicarb, calcium chloride, saline solutions, potassium chloride.
And then our synthetics.
Lidocaine, diazepam.
Mm-hmm.
Guess that's the only 2 that I can pronounce.
Yeah, those are the ones that it lists. So medication administration, what is important to know about your drug before giving a drug to a patient?
The route that it needs to go.
Okay. Before we even get to that,
What's your question?
what's important to know about the drug before we give it to a patient?
Is the patient allergic to it?
Yeah, well, the why. Why does that patient need the medication? So
Right.
Everybody's familiar with albuterol, right?
Right.
Why do you give a patient albuterol?
Wheezing.
Okay, so what does albuterol do?
It's a bronchodilator.
So if you know the why, you know the why it works. So under your medication reference material, knowing the basic information about the drug is one of the most important things that you need to know before administering any drug to any patient. And so Derek, you were starting to go over your well, some say 5, some say 6. What are your rights of drugs for before giving patient administration?
And right patient, right dose, right medication, right route, and expiration. Is expiration one or no?
I think expiration and then right time, like document
Okay.
right time. Mm-hmm.
Yeah.
So they go a little bit more in depth into it, and they call that your medication profile. And your medication profile just profiles the different things of that. So it's got the medication name, the classification, the mechanism of action. What is the mechanism of action?
Like what it's going to do.
Okay.
How it's going to react in the body.
Yep, the intended effects.
Okay.
So when we do our recheck or a reassessment of our patient. That's when these mechanisms of action come into play, because we need to know our intended effect of these medications that we're administering. We don't give them just because we know that we give albuterol for wheezing. We need to know that it's supposed to help them breathe better, improve their wheezing, and improve their oxygenation or ventilation. So knowing your mechanism of action is important. How about indications?
Why you're giving it?
Okay. Your pharmacokinetics.
It says how a drug is observed, distributed to the tissues, and eliminated from the body.
Okay, so why is it important to know how a drug is absorbed?
Like if you do,
'Cause-
like if you're doing nitro paste
Okay,
or like epi 1-to-1,
okay.
you need to know like how long it's going to take if you give too much, if you can wipe it off, if you can't wipe it off, because once you give it, you can't take it back.
So nitro paste and sublingual, which one has a faster reaction time?
Sublingual.
Side effects. So let's highlight nitro. What's some side effects of nitro?
Headache.
Hypotension.
Hypotension. So if we know that these are possible side effects, and we know that the patient's blood pressure is in a lower range, we know to be precautious and kind of look for those signs, right? We don't want those adverse reactions. So we can kind of always think those 2 steps ahead and know, hey, you know, this could cause a drop in his blood pressure. Well, if it's low enough, we know per our protocol, we're not supposed to give it, but you still need to know that it could happen, not just because your protocol says don't do it. Okay, so route of administration. What are our routes?
Oral, sublingual, IM, IV, ET tube. You can give rectal, but we're not going to give rectal.
Okay.
And transdermal.
What is a new skill to you? A lot of those would be new to you anyways at the AEMT level, but what's a newer skill in EMS for AEMTs?
IV access.
Even newer.
Intubation.
And EMS as a whole for AEMTs.
What did she have?
Talking about IO.
IO, yes. Anybody seen an IO? Anybody help assisted, set the equipment up, been in training, hands-on, anything?
Yes.
Yeah. So if you're given a medication IO, do you think that your dosage would change?
No.
Correct. Yep, they stay the same. How about if you're given drugs, let's say for cardiac arrest down the ET tube, would those change?
Yeah, you would double the dose.
Okay. All right, so contraindications. Why are you concerned with contraindications with medications with your patients? Are they going to be the same for every patient?
No.
Are all contraindications going to be the same as far as the reactions that they receive? One might have a slight allergic reaction to something, and somebody might have a severe anaphylactic reaction to them. Dosages. Your dosages of your medications are super, super important. So like the example they give is 0.4 milligrams nitroglycerin. So make sure when it says 0.4, you're not doing 0.04. I've seen that in reports many a times where people actually say that they give the wrong dose, and if it's documented you gave the wrong dose, that's what they're going to think is you gave the wrong dose. All right, so how is the medication supplied? What does that mean?
Like, is it in valves? Is it in pre-filled syringes? Do you have to draw it up, or?
Yep, so what does it come in and what is the concentration? And your concentration is always on the medication itself. So the example it gives you is epinephrine is packaged 1 milligram in 1 ml. which is known as Epi 1 to 10,000. And it's just telling you that in that 10 ml syringe of fluid, there is 1 milligram of Epi. And so that's just breaking it down for you. So our different types of packaging. What are some different types of packaging you may see for medications?
That's the vials or the pop bottles. Some of them come in the push packs.
What do you mean by push packs?
You have to push it through and it'll pop out the back of it. Like for instance, Tylenol.
Okay. Okay. I see what you're saying. What are those called? The foil packs. I can't remember what they're called.
The blister packages.
Thank you. Blister packaging. Yes.
Thank you.
Blister packaging. Okay. So we have vials. We have the blister packaging. What about ampules? Anybody familiar with ampules?
That's like what D50's in, correct?
The ampules are the ones you have to break off and then draw it with the filter syringe.
Oh, it's like Epi 1 to 1.
They're glass.
Okay.
Did you have a question, Crystal?
No, that was Clarissa trying to say hi, Miss Caitlin.
Oh, hey. No, I heard
Okay,
you.
quiet.
I heard a bloop, and then I saw you were highlighted. Did anybody have anything for ampule?
Is the epi in the ampule? Is that the pop one, the one you pop and it breaks easily?
Yep. So typically, what you'll find in the ampules is the Epi 1 to 1,000, and those are with the full glass top. And typically, you have to hit the medication until it goes down a little bit, and then you actually break that glass part off. These are not vacuum sealed like your vials are. So you actually, once you pop that glass top off, and make sure that you're taking like a 4x4 or a 2x2 when you're doing this, so you don't actually cut yourself. After you do that, you invert the medication, and what kind of needle do you think that you would use to draw this medication up?
Filtered.
A filtered needle. And why?
Because you don't want to push glass into there.
Nobody want glass in their veins. Absolutely. So you pull it up with a filtered needle. So traditionally with a vial, when you are pulling up medication, you inject air before you actually pull that amount of medication up you need. With ampules, you do not. If you inject air in that upside down ampule, out comes your medication. So you'll be wearing it, not giving it to your patient. So those are some of the biggest differences between ampules and vials. All right, so let's talk about medication names. What are the 4 names that medications typically have?
They have their generic name.
Okay.
They have their trade name,
Okay.
the chemical name,
Okay.
and the official name.
And the official. All right, so let's break this down. What is the trade name typically? Where do they get the trade name from?
When you say where did they get it from?
So the trade name is basically the trademark of that medication. So your book shows, I'm going to say this wrong. Proventil is the trade name for albuterol. Who knew that? We all call it albuterol, right? You knew that? Okay, so what do we associate, of course, Cliff? So what do we associate albuterol as? What is albuterol? What name would that one be?
Oh, it's the chemical name, the generic name.
The generic name, okay? What would the chemical name show you?
What it's made of.
Yep, it's the precise description and the chemical composition and the molecular structure of the medication. That's straight from your book. All right, so we know the generic name. And typically the official and the generic names for medication are often identical. Okay, so medication forms. Which forms do you think that you would utilize the most as an AEMT?
Liquid.
Liquids. What kind of solid medications can you give?
Tylenol. Aspirin. Nitro.
Yeah, we think of solid medications like our tablets, like our Tylenol. Then it also breaks down into the liquid capsules, your powder capsules, and anything within a gelatin kind of capsule or encasing. Those are all of our solids. So we get into our liquid medications. We look at different forms of our liquid medications. There are 6 listed in your book. What are they? On page 263.
Caitlin, say it again.
There are 6
What was
different
the
types of
question?
there are 6 different types of liquid medications described in your book. What are they?
Oh, suspensions.
Mm-hmm.
What's that? Tinctures,
Mm-hmm.
spirits, elixirs, syrups, and emulsions.
Typically, you'll see syrups on the trucks. That could be like your liquid Tylenol or your liquid ibuprofen, medications like that. What kind of gases would you use in the truck?
Oxygen.
Mm-hmm. Is there anything you want to add, Cliff, before we move on to the next part?
The big problem here are the 4 names, because we kind of interchange these a lot and mix them up and mess them up. So it's difficult for you to just learn one, because a lot of people will use another one for the same medication. So be sure that you're trying to learn as many of these names as possible so that you can tie them with the same medications. Other than that, we're going to spend a ton of time on the medications, and then and all of the administration routes coming up. So, but initially, as you're learning these and they're new to you, I would encourage you to learn at least 2 names for most of these medications. Oxygen isn't going to have 2 names, but most of the rest of them will. So work on that.
All right. I know Cliff was talking last week about the medications that you went over. I think there was 4 of them, 3 or 4 of them. And he highlighted one specifically that dealt with your sympathetic nervous system. What was that medication? What medication that you covered last week deals with your sympathetic nervous system?
It's not aspirin or nitro.
Is it albuterol?
Why do you say that?
We had albuterol and Atrovent were the other 2 we discussed. So I'm looking at my ipratropium, and it's not the one, so it's got to be the albuterol
And
because
what?
it's a vasodilator.
Well, good job, process of elimination, but it's also highlighted on page 264 under your sympathetic nervous system medications. It also highlights
see
and
that.
tells you why. So please read your whole section and reread your whole sections on medications that affect the nervous system. If you don't read this, me explaining to you is not going to mean anything, okay? So please go over that and review that section. That's very, 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 very important, because remember, over in here, mechanism of injury or mechanism of action, we don't know it, we don't know what we're doing to the patient. So please read over that part. All right, analgesics. What do analgesics do?
Reduce pain.
Okay. What analgesics do you think an AEMT can administer? Anybody know a contraindication of why we cannot give Toradol at the AEMT level?
If they're going to go for surgery.
If they're going to go to surgery. So with analgesics, what is your whole goal with giving those to patients?
To make the patient comfortable.
So Toradol, what pain is Toradol really good for?
Flank pain, kidney pain, kidney
Okay.
stone.
Okay.
Kidney
Yep, kidney
stones.
stones, absolutely. Things like rheumatoid arthritis, Toradol is really good for those types of pain. Barbiturates. What is your classification of a barbiturate? Your barbiturates fall under your anti-anxiety.
Sedatives?
Huh? You didn't come through.
Are you asking like an example of one of those?
What class is your barbiturates under? Did anybody read this chapter yet?
So they're used for anxiety, insomnia, and seizure disorders.
Yep, your barbiturates, your benzos, all of those are followed under your anti-anxiety, your sedative, and your hypnotic medications. So what kind of patients do you think that we would use these on?
Psych,
Okay.
epileptic, I guess, like seizure patients.
And why is it important to know this class? Because even if we're not using it, could your patient be using them?
Yes.
So knowing the side effects and the potential, the mechanism of action, if your patient is taking these, if they're prescribed by a doctor or whatnot, knowing how they could be presenting is important. So stimulants. How do stimulants work? What do they do? What is their mechanism of action?
Caitlin, say that again. Say that again. It's going in and out.
You just jumped. You were one place and now you were the other. I don't know if your internet's not good. Can you hear me?
Yes, I can hear you.
Okay. How do stimulants work? What is their mechanism of action? And then Robin answered it. They work at your CNS by blocking your reuptake. So if stimulants, if their action is to stimulate us, what are some possible side effects that you would expect to see from these?
Tachycardia.
Okay.
higher respiratory rate.
Seizures.
So they break them down into different categories. So caffeine. Caffeine's a stimulant, right? It's in soft drinks, it's in coffee, it's in energy drinks, it's in, normal things that we eat every day, even tea, things like that have caffeine in it. What will we see from caffeine?
Increased body activity.
Our heart rate increases, right? That's our goal, alertness. We want to be awake. So something like caffeine is a stimulant. Do you think that we would see seizures from caffeine?
I guess it depends on the patient.
Can if it's too much.
So I would hope not. That's the answer. I would hope not. So typically you shouldn't see seizures from caffeine intake, okay? So don't worry about your morning coffee. But cocaine and, methamphetamine, things like this, could there be a possibility of seizures with those?
Yeah, as well as other things.
Yeah. So knowing the type of stimulant is what I'm getting at is important. So just because they have a high heart rate, don't just automatically start thinking it's cocaine, because like how many of us in EMS thrive with our daily Monster drink and our coffee? Those are our stimulants, but just make sure that you know that they go from one extreme to the next.
Well, isn't ADHD medication also a stimulant?
I believe so, Cliff. I believe it makes your heart rate faster.
Yeah,
No.
all of those behavioral drugs are the ADHD ones are stimulants, where
Mhm.
most of the other behavioral ones are depressants.
Right.
Like as well as Adderall, correct?
Yeah, Adderall is the one. That is the stimulant. That's like basically it's like legalized speed. So people taking Adderall, they're going to be all hyped up, increased heart rates, respiration rates, that type of thing, because they're trying to essentially catch the body up to the mind. So their mind is moving at such a fast pace that the Adderall is trying to bring the body systems up to that speed. But with all of the other behavioral type drugs, you usually see those in the form of depressants, where they're trying to slow things down. And if you have Adderall, you can sell it for good money.
Like how much?
Just saying.
Like how much?
I don't know. I haven't sold any, but I hear it's pretty popular. It
Well,
usually,
moving on.
it usually with, I mean, you see this with on the illegal side, you'll see this a lot with college students when they're getting close to finals, or they have things they've got to get done on timelines. They'll buy these things and hit it and stay up for 2 or 3 days at a time.
Right. Well, because they say if you don't need the Adderall, you don't need those CNS blockers. The Adderall has the opposite effect on you and gives you like all that increased energy and whatnot. Whereas instead of increasing your focus, when people who have the ADHD,
and they swear that it does, it makes them sharper and more focused,
right.
and they can go forever without sleep and stuff. So
Anybody seen that movie?
You may see that.
Was it Limitless? Where he takes like that drug and he's able to do like anything he wants, basically. I swear they made that movie off of Adderall.
So, I mean, you guys may run across some college students or something around the end of semesters, towards finals, things like that. Don't be surprised if you see these things. And they're not going to admit to it because they bought it illegally.
How about depressants? Our depressants can be our benzos,
Yeah.
our barbiturates, our narcotics. When you think of depressants, what do you think that they typically treat?
Pain.
Depressants, they do more than pain.
Depressants also help with sleep
Insomnia,
and stress, anxiety,
okay?
and muscle tension.
There's a couple depressants that we can give, diazepam and midazolam, so Versed, that we can give for patients at the paramedic level for seizures. Why do you think that these depressants, what is their mechanism of injury that can help these patients from seizing or convulsing to help them stop seizing? I said that all wrong. How do they work? Why do they stop them seizing?
Because I know that they slow brain activity,
Okay.
and it's basically like a sedative medication.
Your book just breaks it down into a one sentence how it does. And it basically just inhibits the influx of the sodium into your cells. And that hopefully allows the cell's inability to depolarize anymore, causing that seizure-like activity. All right, respiratory medications. What do you think of when you think of respiratory medications?
Oxygen,
Oxygen.
albuterol,
All right, so when would you use oxygen?
low O2 sats,
Okay,
altered mental status, traumas.
okay,
Basically, give it to any patient, it's not going to hurt them.
okay.
Everything, yes, everything.
So what is our goal in oxygen, let's say in like a trauma patient? Why is oxygen important?
to help perfuse.
Oh, yes.
Yes.
So if they're not perfusing, what are they not getting?
Oxygen to the
Oxygen.
brain.
Okay. What are the 3 things their brain needs?
Oxygen, sugar.
Oxygen, glucose, and blood. So let's say we have a trauma patient. They're bleeding. If they're bleeding, what do we expect their blood pressure to be?
Low.
Okay, we expect it to be on the lower side. Is oxygen going to fix their blood pressure?
No.
No, but hopefully, like Derek said, it's going to perfuse and give that tissue that is lacking the oxygen it needs until we can fix that problem of why they are losing the blood. So yes, oxygen is very, very important. So what are some other respiratory medications?
Albuterol and ipratropium.
Okay. When do you want to give those?
Wheezing, asthma patients. Emphysema, can you give it to emphysema patients because they're tight? Possibly.
Yeah, they probably got some wheezing going on, yeah.
Okay.
Yep.
I know another medication is racemic epi.
Oh, good one. So what's racemic epi?
It is nebulized epi.
Nebulized epi. Okay, which one?
1,000.
Epi 1 to 1,000. Okay.
And it's indicated in croup, however you say that word.
Yep, croup. And croup is what type of airway obstruction?
Is it upper?
Upper, absolutely. Yep, croup is an upper airway obstruction. So that racemic epi, if you're not familiar with it, Cliff, is racemic epi in the national AEMT?
Yes, I believe it is.
Yes.
Okay. So racemic epi, I think different places have different mixes with the saline, but it is 1 milligram of epi 1 to 1,000 in 2 mLs of, it's usually 2 to 2.5 mLs of normal saline, and you just mix it up in basically your dual-neb treatment, and you give it to them like a dual-neb. It's nebulized oxygen.
And that is only for, I mean, of course, because croup's only in infants, but what's like contraindications for that, or is there any?
I would say it would be the same thing as anything that they would have for regular epi.
So just heart rate.
Right. Are they unresponsive? Of course, we can't give them anything, unresponsive that way. But remember, if they're in respiratory distress, they might have an elevated heart rate anyways, just from the distress from trying to breathe. So just take those factors into play too.
Is it still like anything past 150, or does it change for an infant?
Oh, it definitely, yeah, the heart rate changes for an infant because theirs is already at a higher rate. Yeah.
Like, what is the contraindication for the heart rate? Do you know, Cliff or Caitlin?
It might just say,
It's going to be aged.
Yeah.
It's going to be age dependent. So, I mean, if you were dealing with a 50-year-old, 150 is a good number. But if you're dealing with a 3-month-old, you could probably go up, closer 160 to 180 maybe.
Yeah.
That
And
unfortunately, there's probably no set hard line for this.
Okay.
And it will probably, because a lot of your medications in your book will tell you to refer to your local protocols. So whatever typically is highlighted in your local protocol is what it's just telling you reference to.
Okay.
Solumedrol, yes, that is a paramedic drug, but your book does tell you to reference it. I guess just to know what it is. Solumedrol, that's our steroid. All right, so now we're moving on to our cardiovascular medications.
Epi 1 to 1, Epi 1 to 10.
Okay, well, Epi 1 to 1.
Well, no, sorry, Epi 1 to 10.
Yeah. So Epi 1 to 10. Yep. Anybody know when we give that?
Cardiac arrest.
Cardiac arrest.
Yeah, what route?
IV or IO. Or you can go ET.
Is anybody familiar with with Epi 1 to 10 looks like? Epinephrine 1 to 10,000.
It's in a pre-filled syringe, correct?
Typically, yeah.
Or, I mean, it could be. You could have to draw it up.
What are some other cardiac drugs?
Normal saline one? Yes or no? I mean, it goes intravenous, so I don't know.
I mean, if you look down into it, it could be because it's basically salt water, so it's sodium, electrolytes. So I'm not saying no, but
Ni-
Demetra and none of that came through.
Nitroglycerin.
Yes, nitroglycerin. When do we give that?
I'm
Chest-
sorry. I think it's my internet. I keep going in.
Yeah.
Chest pain.
Okay. Chest pain. All right. So we've covered like routes and contraindications and indications. So we know nitro, and that is one of the drugs you've already been over. So you should all know this. So we know nitro is for chest pain. Okay.
Aspirin.
Aspirin. What are some contraindications for nitro?
Hypotension.
Male enhancement drugs.
Okay.
Hypotension.
Hypotension. What range of hypotension?
Systolic needs to be at least 90 to 100.
Okay. What are some other contraindications?
Is it head trauma?
Mm-hmm.
GI bleeds.
For nitro,
You don't want to give it for that.
what is the one contraindication you will have for every single drug?
Allergic?
Yep. Hypersensitivity. I don't care if it's oxygen. If they ask you that on a test, hypersensitivity, always. Okay. So nitro, what route would you give that?
Sublingual?
Sublingual.
Sublingual. Okay. We instruct them to what? Not to chew.
Yeah, just put it underneath the tongue. Let it
Okay.
dissolve.
So since we know its mechanism and we know that how it is absorbed, how do you want to handle this medication?
With gloves?
Go a step further even from gloves. Get a medication cup or something to pour that medication into. You just don't want any, I've never seen it happen, but I'm not going to say that it won't happen. Just go that extra step and be precautious so you don't get any of that nitro absorbed into your skin. Okay, so nitro sublingual, typically for chest pain. What are some other ways that we can give nitro and what for?
Paste.
Okay,
You can give that for congestive heart failure as well.
okay,
Yep, CHF.
CHF. And I think y'all covered everything last week pretty well on nitro paste, how to apply it, when, All right. So we did name one drug that we wanted to give with chest pain, and what was that?
Aspirin.
Aspirin. All right. What is aspirin?
I don't know the classification. I know it's supposed to lubricate the red blood cells.
It's a platelet inhibitor.
It's an antiplatelet. Okay. So why do we give those in chest pain?
Just in case there's a blood clot or a blockage.
So what is chest pain?
It's a blockage. Ah, Robin. Good job, Robin.
So in chest pain, we can have angina, stable angina, unstable angina, but chest pain, the pain is typically because of there's some type of ischemia. There's some type of lack of perfusion. There's some type of tissue in there that is not getting the blood or oxygen it needs. Why? We don't know. We can't see, but what we can do is treat what we think is going on. So when we give aspirin, what we're trying to do is reperfuse that area that is not getting that blood flow, that lack of oxygen, to prevent any of that infarction. We don't want that to happen. So, oh, that was trippy, Cliff. So if we give these nitros, those dilators, if we give these anticoagulants, we are able to hopefully prevent any infarction of this heart muscle. What's infarction?
Death.
Tissue death. Yep. Yep. So with these chest pain patients, important, aspirin, nitro, if they can have it, and oxygen, those things are very super important. If you get those things started, the hospital can finish with them. I think I mixed up antiplatelet and anticoagulant. So what's your anticoagulants?
They prevent clotting.
And what are some ones that we typically see patients take that are prescribed by their doctors?
Plavix.
Okay.
Coumadin, warfarin.
Lovenox.
Yep. So typically our older generations are the ones that we're going to see on these because they have that coronary artery disease. You know, their hearts are getting older. So they are on these. What are some worries when we see these for call types we go on and think, oh, this is important, that sample, that medical history, this is important to know so we can better treat this patient? What are some calls that come to mind knowing this information? Strokes, falls, yes, Robin, those are very important.
Chest pain.
Yep. Abdominal pain, how about the I woke up throwing up blood, or I'm having coffee-like bowel movements, you know, things like that. It's important to know because if we're thinking any type of bleeding, especially internally, we want to know how advanced it could be depending on those medications they're taking. All right, so diabetic medications.
Glucose, D50. D10, D5W.
Yep. So type 1 diabetics, what do they lack?
Insulin.
Insulin, right. So these type 1 diabetics, they can't make that insulin, right? So what typically happens to their blood sugars?
or high. They're generally high blood sugar.
Yep. So like that video that we showed last week, these type 1 diabetics, they have the glucose, they're able to make that, but they don't have that fuel opening that's called insulin to actually let the body process that glucose as energy. So then the body is like, we're going to store it up and we're going to use something else like fat or something for your energy. So those glucose levels rise and rise and rise. So they typically become hyperglycemic. What are your thoughts if you go to a patient that is type 1 diabetic and they are suffering from hypoglycemia?
They gave themselves too much insulin.
They what?
They gave themselves too much insulin or gave the wrong insulin, the fast acting versus the
Yep.
long acting.
Yep, they could have taken the wrong insulin. They could have taken too much insulin. Some patients have a daytime insulin and a nighttime insulin. Sometimes they get their sliding scale off. They just take the wrong amount. Sometimes things like UTIs and fevers can actually make their body react different and to the insulin, and it burns it up too much to where they use way too much glucose because they're sick. Their body needs more energy, right, to heal itself. Type 2 diabetics, what do you typically see them on?
So, metformin, Januvia, Amaryl.
Is everybody pretty familiar with absorption? And depending on the route we have an absorption, the track it goes through, and the way our body processes it. So if we take a medication orally, where do you think it's going to start absorption? Where at in our body?
Well, it's going to start breaking down in your mouth from the saliva, but then it's going to go down to your stomach.
Okay. How potent do you think this medication is if our absorption is through our gastrointestinal tract?
Are you asking like how well it works, or?
Yep.
It's not going to work as well as it would as if you put it through IV. That's why your IV dosages are less than oral tablet.
Yep. Yeah, you've got to think of all the processes it goes through, and also, you have things against you like stomach acid and things like that. And then it also says that, this is a funny word, your duodenum, that's actually where we take our PO medications. That's actually where it's got the most potential for absorption, is in the duodenum. That might be, I don't know, words like that always pop up somewhere. So how about drugs like IN? I don't think that was one that was listed before for different routes. What kind of drugs can we give IN?
That would be your nasal sprays.
Okay.
Narcan.
Yeah, your nasal area is very vascular. That's why like nosebleeds bleed a lot. So they take like the Afrin, that constrictor, to stop the bleeding. Things like Narcan, yes, they can be given IN. Same form that we carry on the truck, really, that we would give IV. You can actually connect what they call a MAD device. And it basically just screws on the same lock lure that you would to your IV. And it just makes a mist out of it. Nothing else fancy. You don't have to mix it out with saline or anything. You just spray that straight in the patient's nose. So yeah, because it's so vascular, the rate of absorption is pretty fast. There's other drugs like at the medic level that we can give IN, but typically you see like the Afrin and the Narcan prominently. And then of course, IV. What drugs can you give IV?
Toradol.
Okay. There's a lot, right? What do you think is the one that you were going to give the most at the AMT level?
What was the question? Sorry, my computer messed up.
You're fine.
Normal saline.
Normal saline, yeah. With what what drug do you think you're going to give most IV route at the AEMT level? Yeah, normal saline, you're going to give a lot. It has a lot of uses. Cliff, is there anything you need to add so far?
I'm sorry I missed you for a few minutes. I was out.
We finished up all the pharmacokinetics, heading into more of the medication effects.
Okay. No, go ahead and I'll just throw in some tie up stuff at the end here if I can.
So what are some things with medication administration that you think you might get different responses? Like, what are some influences?
ETOH.
Okay. How about age? Why is age a factor?
Because some older patients, their bodies can't absorb medications like a young person can.
Okay. So a baby, are you going to give an infant the same medication that you would give an adult?
No, ma'am.
No. So knowing the age is important. Gender and body mass can be a factor as well. I wouldn't go into your protocols and dig and say this patient weighs this, you have to give this, and this patient weighs this. The only way I would see that is like in the Broslow tape section. But I think the way protocols cover that is, you know, after 5 or 10 minutes or whatever, reevaluate and then re-administer another dose if you would need to, depending on the medication. So I think that's how they factor in maybe the body mass area. Pathogenic state. If anybody is tracking with me, we're on page 271. What do they mean by pathogenic state? That deals with patients with significant liver or kidney disease, or liver disease or kidney failure. So what's like one drug you want to give somebody who has liver disease?
Aspirin.
Yes, Robin, Tylenol.
I want to give them an NSAID
Why not Tylenol?
because it's an NSAID.
Because that's where our body breaks it down. That's what our body does with it. Yep, it's processed through the liver. This is Tylenol. When you have those people who overdose on Tylenol, they're not quick deaths. They're actually very slow deaths. They're painful. Their body goes through the processes just like somebody who has liver disease because of the fact of that's where the Tylenol is processed, and they are just doing it through the OD process. Very painful, very slow death. But yeah, so because that's where it's processed is through the liver. Time of administration. Why is that important? Let's say a patient you go to someone, they go, oh, well, I'm having abdominal pain and I took an aspirin before you got here. Is it important to know really how long before you got there?
Yes.
A lot of times when you go to a patient's house and you ask them a question, they'll answer it just like they're answering to somebody else. But if you reiterate and let them know why the almost trying to get an exact time is important, then it will make them think a little bit harder and answer you a little bit better. Say, well, we really need to know because with this abdominal pain, I want to make sure you're not, having any internal issues. So do you know around about a real time that you took this aspirin? So just explain things to them. And then medication storage.
Some medication
where do
are
we-
subject to temperature and light.
Yes. So what's one drug that you can think of that is sensitive to light?
Nitro.
Nitroglycerin.
Mhm. Where do we keep our medications?
In a locked box.
Okay. Where's that lock box?
In a dark cabinet.
Those boxes are kept on the ambulance, and those ambulances are always in a perfect tropical setting. So those medications are always at a room temperature, and they are never in hot situations or cold situations, and they are always in dark places. Does that happen all the time?
No.
No. So with nitro, if it's exposed to light, what happens?
It weakens it.
Okay. That medication is not as potent. That medication is not going to do its job. So what were our intended results of this medication of nitro?
Relieve chest pain.
Relieve chest pain. Maybe if they're hypertensive, maybe one of the good side effects is bringing that blood pressure down. But what is the side effect that the patient might feel?
A headache.
Headache. So, like Cliff said last week, if they're not experiencing these things, what do we have to look at maybe?
Expiration.
The medication.
Maybe that medication is no good. Maybe they opened it 4 months ago and haven't used it since, and it's in date, it's been kept in the dark, but it's just not working. So just make sure that your medications are stored properly at all times. And I know a lot of agencies will actually date their medications when they open them, like things like nitro, because they do have a very short shelf life depending on how they're handled. If you're given a drug like nitro paste, so we know nitro paste is what route?
Topical.
Okay. So it's that transdermal drug
Transdermal.
action, correct? Transdermal. What are some things that we want to look at and evaluate the skin? What are some factors that we would not place that nitro paste on?
If they had a pacemaker.
Okay.
If there's a wound there.
A wound, absolutely.
If they're diaphoretic.
Okay, they're diaphoretic, you can probably wipe them down, but yeah, diaphoretic might show a sign of what also? Something's going on, right? They're diaphoretic. Their skin is showing you a sign and a symptom of something going on. How about burns and rashes and things like that? All right. So that is section 3 of pharmacology. And Cliff, I know you had, I don't know if you're there, Cliff. I know you had mentioned going over their new drugs. I did not pull them up. I don't know if you have them.
They have drug list 2 is 4 more drugs. So should be oxygen, epi 1 to 1, epi 1 to 10, and diphenhydramine.
Benadryl.
So those are the 4 for this week.
All right, so let's talk about oxygen. We talked about it a little bit before, what the uses are. How would we give oxygen?
Nasal cannula, CPAP, non-rebreather, blow back, CEM.
So nasal cannula, how many liters per minute would you apply for nasal cannula? What's the range?
2 to 6.
1 to 6.
Yeah, typically 2 to 6. So your non-rebreather,
1 to 6.
does your book say 1 to 6?
15 liters. My little book did.
Your what?
Can you hear me now, Caitlin?
Uh-huh.
Okay. Yeah, my one of my other references that I use, my other book, it said 1 to 6.
Okay. Make sure you get them from this book. Okay. I know a lot of books will say different things. All right. What about our non-rebreathers?
Okay.
Is it 8 to 15 liters?
10.
And then what about our bag valve mask?
15 milliliters.
So at what point do you decide does a patient need high flow O2 BVM versus high flow O2 non-rebreather?
Depends on O2 sats and how they're presenting.
Okay. Yep, remember, just because they have good oxygenation at first doesn't mean they have good ventilations. So BVMs typically is when those patients need that ventilatory support. So we are assisting them with breathing with the goal of keeping their O2 saturation within a normal limit. All right, so we talked about epi 1-to-1. Talked about epi 1-to-10. So epi 1-to-10, what is your common trade name?
Epinephrine. Adrenaline.
Adrenaline. What's the class?
Sympathomimetic. Sympathomimetic.
Okay, what's its mechanism of action? What do you want it to do?
Vasoconstrict and bronchodilate.
So right here, if I can jump in for a second, a sympathomimetic drug, as Demetrius said, vasoconstricts and bronchodilates. Which central nervous, automatic central nervous system is this comparing to?
Parasympathetic.
Not the
Sympathetic.
parasympathetic.
Sympathetic.
This is the sympathetic. It's right there in the name of the class, a sympathomimetic, which means it mimics the sympathetic nervous system. Okay, so it's going to give you those effects just like the sympathetic nervous system would if it was working on its own. So if you see a drug that says it's a sympathomimetic, it's mimicking that system. If you see a drug that says it's a parasympathomimetic, it would mimic the parasympathetic system. And you'll see those at some point. So so just keep that in mind. So when they say sympatho or parasympathomimetic, and you see the mimetic on the end, that means it's mimicking those systems. And the effects are going to be what they would if those systems were working on their own. Okay.
So if epinephrine 1-to-1000 or adrenaline affects the sympathetic nervous system, what do you want to happen to their heart rate? What would happen with their heart rate in a response to the sympathetic nervous system?
Increase.
You want it to increase. That is our goal. And what are your indications for epi 1-to-10,000?
Cardiac arrest.
Okay, specifically.
Are you asking what arrest? Asystole? Is that what you're asking for?
Mm-hmm.
Okay.
And anaphylaxis.
Demetria, that's 1 to 1,000.
Yeah. Yeah, your epi 1 to 10,000 is used for cardiac, and your epi 1 to 1,000 is used for your anaphylactic. Your epi 1 to 1,000 is the one that you want to give IM. They're the same medication, just epi 1 to 10,000 is diluted 10 times of epi 1 to 1,000. Epi 1 to 1,000 is just a lot stronger. Yep, you can give it in cardiac arrest, and you can have the VFib, pulseless VTAC, PEA, and a systole. What's your dosage?
0.1 milligrams per milliliter.
What's your adult dosage of epi 1 to 10,000?
0.5 to 1 milligram.
0.3 to 0.5.
What's
Yeah,
your
that's 1 to 1.
what's your adult dosage of epi 1 to 10,000?
You asking me?
Anybody?
Oh,
Robin got it. Ding, ding, ding. It's 1 milligram.
That's
And
what I
you know I
said.
got that right
0.5
here.
to 0.5 to
No.
1 milligram.
It's 1 milligram.
So it's not 0.3 to 0.5.
No, that is your epi 1
That's-
to 1,000.
I got them mixed up.
Yeah, you do. Yeah, you do.
Oh my gosh.
Don't forget your pediatric dose for epi 1 to 10,000 is different as well. That is your 0.1 of mLs per kilogram of epi 1 to 10,000. So that's when your fun drug calculations and conversions and whatnot come into play, or your wonderful Broslo tape. What was your last medication?
Diphenhydramine.
Benadryl. I just gave you the trade name, Benadryl. We all know Benadryl. What's your class?
It's an antihistamine.
Okay.
And you give it for moderate to severe allergic reaction, anaphylaxis. But you give it after epi.
In
Allergic reaction.
yep, for your severe,
Yeah.
yeah, but you're mild, you can give the diphenhydramine. I know of the contraindications that Cliff, I believe, no, that was albuterol, never mind. But of course, Benadryl, diphenhydramine, everybody knows that one of the side effects is what? What's the big side effect you hear about?
Sleepiness.
Yeah, drowsiness and sleepiness. But we don't really hear about is possible hypotension, the palpitations, tachycardia. One of the drugs that you can give, it just left my head. I can't remember. We give it for possible psych patients.
Haldol.
Thank you. So Halidol you see with patients sometimes they'll have that dystonic reaction. I could not think of it, but they'll kind of like move their jaw and they're having like these weird movements and they're actually having almost like an allergic reaction to the Halidol. So what they'll do is they'll actually give them diphenhydramine with it, which Halidol calms them down, give them diphenhydramine on top of it, and boom, they're just kind of sleepy after that. But a little off topic, but if you ever hear somebody have an allergic reaction to Halidol, that's typically what they do. They just give them Benadryl. It's that histamine blocker. What's our dosage of Benadryl?
25 to 50 milligrams.
And 1 milligram per kilogram for peds.
Yeah. So your book does say, because I don't know if this, I do agree with the 25 to 50, because that's North Carolina state. But your book does say 10 to 50 milligrams IM or IV, up to 400 milligrams per day. That's weird. We don't do that. We're not going to keep a patient for a whole day. And then pediatrics, yes, your book does say 1 to 2 milligrams per kilogram. Your medications are in the back of your book. They actually list everything out for you that you would need, your class indications, contraindications, everything, your dosage right in the back. So for testing purposes, definitely to go over those in case they do, because we pull all of your questions from the test bank. Okay, so one of the notes in there, so we said what? That the Benadryl makes you sleepy, okay? And so one of the notes is to look for respiratory depression. And it specifically states because the diphenhydramine can increase the viscosity of the bronchial secretions and use in caution with asthmatic patients. So what are those?
As well as COPD, correct?
What do those two factors mean? Like why?
Because it slows your respiratory rate drive.
Yeah. So if we're slowing our respiratory drive, we already have asthma. Now we've got this Benadryl coming in there and thickening stuff up, and we already can't breathe. What are we causing?
Edema, pulmonary edema.
A lower airway obstruction. Yep, we are causing this patient to not be able to perfuse. We are possibly putting them in respiratory distress. I think that's an extreme case. I've never seen it happen, don't want to see it happen, but do remember that that is something that is a possibility. Cliff, I told them to make
Hey,
sure.
did anybody, hey, can I catch one more thing with Benadryl?
Yeah.
Did anybody get information about it making people hyper rather than drowsy? No. It's more rare, but just so you're aware, there is a small class of people that Benadryl will actually make them hyper rather than drowsy. So if you give it to them and they get all jacked up like the Energizer Bunny, just know that they're in a special small class of people. So be aware of that. Don't think that your Benadryl's not working because they didn't fall asleep, but it's probably working and they're just in that special class. So obviously more people are going to be drowsy, but there is a small special group that'll be hyper.
I told them to pay attention to their book because things like the diphenhydramine has the dose actually 10 to 50, where we typically see like the 25 to 50 range. So I don't know if that would come up in a question or something, that it is different than what they're usually used to seeing.
Right. And 10 comes, is that in the adult dose or the pediatric dose?
The adult.
Okay. Well, that's stupid.
Yeah. Yeah, because Derek said 20 to 25. I'm like, you're right, but just in case.
25 to 50 is what everybody's going to know. I don't know that there would ever be a test question you would see that would drop the adult dose down to 10.
Right. All right, and then we're supposed to go over, I believe, IO access. I can hit the major points and then we can go over if you have any questions, but the biggest thing with IO is when we place it. That's when you're really going to learn. So just get familiar with the landmarks, how you're supposed to hold them, how you're supposed to put the equipment together. It's not hard. Just make sure you're familiar with the terminology when we go over and do it in class. I think will be the biggest help. So is everybody familiar with like the Easy IO? Because that's what basically everybody uses, and that's what they show you in these pictures. So your
Yes.
Easy IO is a handheld, basically bone drill. Okay, so IO is intraosseous. Okay, that's where the space that we want to get to. And the way we do that is with a hand-powered drill and a needle. Typically, these come with 3 different size needles, depending on your patient's age and body mass. So typically, with pediatrics, we will go into the tibia tuberosity, which is in the knee region area. It's typically 1 or 2 fingers below the kneecap and then 1 finger in. So it's on the inside of your leg if you're looking at the patient. So we give that for pediatrics. And then adult patients, you can do the humerus head or your tibia tuberosity. So our goal with this is patients that we cannot get IV access on. So then we'll move into the IO route. Same thing we said when medication administration, it is the same amount. One of the big differences is when we are giving IV fluids through the IO, you do want a pressure bag because you got to think when we are in the IO space, there's bone marrow there. So we need to displace that bone marrow, and to do that, we have to cause pressure. So pressure bags need to be utilized, and we'll definitely go over those in the labs as well. So basically, when you choose your needle size, choose your site that you want to go to, your equipment's together, and your needle basically just attaches with a magnet onto your drill. You go to your area, you prep it, and you come up at a 90-degree angle on the bone. You pierce the needle in until you feel it hit the bone, and then that's when you pull the handle on your drill. You do not press down. We do not want that to happen. You let the drill do the work. So the drill will start to pull you in. You put a little bit of pressure, but it's not like you push your whole body weight into it. But as the drill goes in, you'll hear it start to let off, and that's when you know that you should be in the right space. Just because your needle is a certain depth does not mean that it has to go all the way in. All right. So when you think that you are in the correct space, you can take the cap off, take the drill off, take the cap off, and then if you look on page 19 or 1091, it will show you your tubing and your saline, typically a 10 ml saline syringe and your tubing that comes in the pack of the Easy IO. And you can actually attach that and aspirate, means we're going to pull back. And our goal is to see bone marrow in that tubing. If you don't see bone marrow, it's not a 100% that you are not in the IO space, but it is a good indication if you do get that pull back, that aspiration of bone marrow, that you are where you need to be. So then you will advance and push that 10 cc's or 10 mLs of saline into the IO space. Of course, it will feel like it's a little rigid at first because, again, you're displacing that bone marrow. But once that's in and you don't see any swelling, you can go ahead and hook your bag up and start giving your medications. So swelling you might not see right away, so it's very important to monitor IO access to make sure that you are not infiltrating and you've lost that IO site. If you do, you can just move on and go try find another one. So since it's going into the bone, what are some contraindications that you think that you might need to look for before placing an IO?
Broken bones.
Broken bones, yeah, those are a no-no. You cannot do an IO with broken bones.
Burns.
Burns, okay.
And your like CHF patients, like pitting edema in the legs, that's gonna impede your access in the leg.
Okay. How about metal plates?
Hmm.
Can't get through those.
How are we gonna know though? Like scars?
Yeah.
Scars, absolutely. Scars. I see Cliff laughing. What about family around? Getting part of our sample medical history. But yeah, scars. Or you go to and you can't. You try that leg and you just can't get through. It's happened before. So you just go to plan B and try something different. So at the AEMT level, when do you think you would do an IO? What calls?
Unresponsive cardiac arrest.
Cardiac arrest. Typically, cardiac arrest is at the AEMT levels when you would be utilizing the IO. These are typically the faster accesses because, cardiac arrest, there's no perfusion, there's no blood moving, so we don't get those nice plump veins and that flashback saying that we are in the vein when we do IVs. So typically, the IOs are a little bit more user-friendly during codes. They're out of the way. You don't have somebody up in the airway region trying to start an IV in the AC in the arm. So they're typically the go-to. And your patient's unresponsive. If you have a responsive patient or even a patient that is slightly unresponsive or altered and you decided to give them an IO,
They're not gonna be unresponsive very long.
yeah, you're going to push that saline flush, and that displacement of that bone marrow, it's pretty painful. And they're going to come up and let you know it. So I just think the best thing for you to do is read over your procedure for your IO. And then once we do the hands-on portion, it'll be like, oh, and it will kind of click in. They are super simple. They really are. I think the worst thing is sometimes your placement. So if a patient's in cardiac arrest and they have CHF and kind of some of that pitted edema, I might still start it in that leg. I just might have to pay extra attention that my landmarks are correct. Any questions on the IOs?
So what if it was a diabetic emergency? You could not get a line. Nobody else. You're with a basic, and you cannot get an IV line on him. Can you drill him at that point?
It depends what's in your protocol. I don't think that your book would say that. I don't know if your book, because this is an appendix, because a lot of typically, I believe at the AEMT level, they typically don't do IOs. Correct me if I'm wrong, Cliff, for the national, but state North Carolina says that you can. Is that correct?
So for testing purposes, can we IO? Yes or no? He must be asleep.
Yes, you can IO. The national level doesn't allow ET intubations.
Okay. And again, in your book, it'll probably just say refer to your local protocols. And your local protocols will break it down to if your patient's unresponsive and they have to have like different checks, unresponsive and they're like hemodynamically unstable or something like that. Because if your patient is hypoglycemic and you cannot get IV access, what is another drug that you can give IM?
Glucagon.
Mm-hmm.
Okay.
Caitlin,
Uh-huh.
I have a question. The oxygen um values and everything. And I'm looking at the medications in the back of the book and I don't see oxygen. So what does your book say about oxygen as far as the liters per minute?
I got the same book you do.
I know, that's what I'm saying. I don't see oxygen and I don't see. So are they telling us in this book these are the drugs we can give?
No, that's not what they're telling you.
Mm-mm.
That's what I was trying to say. They way different.
What's the problem with oxygen?
I had some different values for the oxygen, and I don't see them in this book. I don't know.
Okay,
Anisha,
so
what book do you
here,
have?
look,
She
I got
wants to
the new
find 'em-
book.
She wants to
Don't-
find them specifically in the book because she got her resources from not that book, from something else.
Right. I have this
Mm.
book. Is this the book?
Yeah.
That's it.
yep.
I don't see
Okay,
no oxygen.
let me make oxygen simple for you. Your numbers are going to vary based on your regulators because everybody does not carry the same graduation on their regulators. So when you start turning in that numbers, depending on where you're working or what agency you're with. So nasal cannulas work up to 6 liters. So from nothing up to 6 liters is what you can use, but it's going to depend on your graduations. In our EMS world, we usually don't do anything less than 2. But you may see people on home oxygen or in different circumstances, they may be on 1 or a half or a quarter or something like that. But typically we don't do anything less than 2, and usually it bumps up, it may bump up in 2s, although some people may have a 3 on their regulator rather than just skipping from 2 to 4. But usually that's how we graduate up, 2, 4, and then 6. But anything up to 6 for nasal cannula. Non-rebreathers we typically do at 10 to 15, although they will work at 8. But they cannot go lower than 8.
Okay.
So, but typically we're going to be in the 10 to 15 range with them. BVM's always going to be 15.
15.
Nebulizers are usually 6 to 8. And then if you do a CPAP, that's gonna be dependent on the device as to what the oxygen requirement is, because all of the CPAPs are pretty significantly different, and so it'll depend on the CPAP for what your oxygen requirement is.
Thank you, sir.
All right.
For testing purposes, they have your flow rate on page 407. It's your nasal cannula, your simple face mask, your venturi, partial rebreather, non-rebreather, and your back valve mask. And like he says, it changes.
Thanks, Caitlin.
You're welcome. Who's all gonna come to Perquimans Wednesday for Demetria?
Me.
Me.
Cliff, are you gonna be here Wednesday?
Yes, I'll be there Wednesday.
Okay. I work at 24, so I'll be here if I'm not on a call.
Cool. I work the day shift, so I'll be there.
Okay.
Me too.
Oh, do you really? Okay. Wow. All right.
Outstanding.
I work too, Cliff.
Nobody cares, Crystal.
I'll come find you. You can't go but so far.
Oh gosh.
I can go all over the county.
You'd be nice. She'll send you on that 5:45 911 call.
I was hoping
I'm
for
not
one
taking-
last time.
I'm not taking it, so don't send it to me.
Oh, you'll go where we send you.
So pharmacology isn't, I'm pretty shocked that we made it this far in time because I thought pharmacology would be done with fairly quickly. It's a quick chapter, but it covers a lot of important items. So getting used to your trade name, your chemical name, all those factors, like Cliff said, just get used to those ones that you typically have to see. A lot of times your medications aren't going to be what you think they are in your drug cabinet. So, you know, your Tylenol would be acetaminophen and things like that. So make sure that you know the name. So when you're on a call, you're not freaking out and be like, oh, I cannot find this drug. What is it? So like Zofran, everybody knows what Zofran is. It's for nausea. But Odonostron is a whole nother factor. So just make sure that you are comfortable with those. And your vials, there's always a vial test or question, ampule question, things like that. So make sure that you get those in place if you have any confusions on those. I think your mechanism of injury and your routes are really, really, really important. Does anybody have any questions?
I got a question for the group. Do y'all have any study groups, fellas and ladies?
What was the question?
Do y'all have any study groups for the test Wednesday?
I haven't heard of any.
Okay. Thanks.
Well, I have nothing else.
Hi, Miss Caitlin.
Okay.
Go ahead, say hi to her.
Hi.
Hey, Princess, are you learning about medication?
Driving me
Uh-uh.
Okay, you happy now?
Tell mommy, say, mommy, I want some Benadryl.
Heck yeah. Double shot.
Oh, B medicine. Stop.
Yeah. All right. Well, I have nothing else. I don't know if Cliff has anything.
Hey, look, real quick before y'all go, I just want to kind of wrap this up. The pharmacology section deals with they have some big words in here. One is pharmacokinetics, the other is pharmacodynamics. What they mean is what this medication is doing to the body and how is it lasting, traveling, metabolizing, those types of things in the body. So what we want you to understand, our end goal is for you to know what the problem is with the body, what's going on in the body, and how this medication affects the body, which is why it works and why we use it. We don't want you to simply know that somebody's having an asthma attack, give them albuterol, or give them albuterol and Atrovent, and not know what to expect from these medications. If you're giving medications and you don't know what they're supposed to do or what to expect from them, that's probably going to lead you into a bad place at some point. It's kind of like trying to make dinner if you're trying to cook something that you've never made before without a recipe. It probably won't work out real great. It may work, it may not, but in all cases, it may not turn out good. So put some work in on these medications. That's why we're giving you these lists in small bits. I mean, I could have given you one list that had 30 some medications on it, but that's a little overwhelming. So we're giving it to you in small bites. We're letting you do these week by week. So take the time, work on them, but not just making the card. That's not the end. You need to study these things, learn them, learn the doses, learn the routes, learn the contraindications and indications. All of this is going to be key for you, and it's only going to get bigger and bigger and bigger. So we're trying to give it to you in small bites, but you need to take those bites and chew right now. Otherwise, you're going to be trying to eat the whole steak in one bite later. So, which is going to make you choke. So this stuff won't ever go away. It's building, so we're just going to keep building. So we're just going to add more and more, and we're going to need you guys to stay on top of these things, okay? All right, so fast pace a little bit. We have Module 2 exam this week, so when you come to the lab, be ready for Module 2 exam. You have the 4 chapters, 7 through 10, and you have some study aids to help you. You have your quizzes that you can go back and look at. You have your book, which is where all of the answers are. Believe it or not, they're all in there. So look at those, and then we'll see you for the Module 2 exam, and then we're going to do the lab on IVs and IOs. All right. All right, I'm good.
Thank you.
You guys have a great night, and we'll see you at the labs.
Okay. If we have any questions on any of the handouts, so you'll go over them beforehand, or I can just hit you up on Wednesday. Because there's a couple that
What's your question? What is your question?
I sent it to Caitlin and it's not clear. Your questions are not worded well, Cliff. Mr. Be a
My
Man.
question. Those aren't my questions. Those are